Thanks, Dr. Lang, and thank the organizing committee for the opportunity to speak with you this afternoon. So I have no disclosures. So I'll be primarily talking about task-based functional MRI this afternoon and how we use it for preoperative planning in patients with gliomas. It is well known that task-based fMRI is well established for preoperative language and motor mapping. It's been shown to decrease OR time, minimize the need for an awake craniotomy, and reduce the extent of direct cortical stimulation. And it has largely replaced WADA testing, which is an invasive procedure for the determination of hemispheric dominance in these patients. So the physics of functional MRI is very complicated, but briefly, if there's a stimulus, there's increase in neuronal activation, and this results in increased blood flow and blood oxygenation to the area that is being stimulated. It is these increases in blood flow and blood oxygenation that results in what we call blood oxygen level dependent fMRI signal. So this is the basis of these fMRI signals that we see. So with regard to language, the two areas that we're most familiar with are Broca's area and Wernicke's area. Broca's area is situated in the pars triangularis and pars opercularis, and it has a role in speech production. And Wernicke's area traditionally is located in the posterior superior temporal gyrus, and its role is involved with speech comprehension. The Wernicke's area and posterior language tends to be more widely distributed. So often we see activations even in the posterior middle temporal gyrus as well as in the inferior parietal lobule and Geschwin's area. So as we all know, language is much more complicated than Broca and Wernicke. And the current concepts of language is that it's widely distributed and that there's two major language streams. There's a dorsal stream that is involved with phonological processing or speech sounds, and a ventral stream that's involved with semantic processing or word meaning. And all of these eloquent language areas are connected by white matter tracts. And there's this nice article by Chang et al. From UCSF in which they did extensive stimulation studies of all these white matter tracts. And there's specific speech deficits or speech arrests in these specific areas. So for example, in the inferior frontal occipital fasciculus, you would get semantic paraphasias. So the concept is to preserve the eloquent cortices as well as these white matter tracts. So how do we obtain these functional MRI images? We administer paradigms to the patients, and there's different paradigms that stimulate different areas. So we administer a letter fluency task and a category fluency task to localize the anterior language network or Broca's area, and a sentence completion paradigm to localize the posterior language or Wernicke's area. And often, although they're specialized for the anterior and posterior network, often there can be overlap. And so this is an example in which we see strong fMRI activation in the inferior posterior frontal lobe anterior to this infiltrative opercular insular glioma. And so this represents Broca's area. Now, in addition to Broca's area, there's an area called the ventral premotor cortex, which is just posterior superior to the pars opercularis. Now, this area does not activate with fMRI because it is involved with speech output. And the activations that we see in functional MRI are related to cognitive processes, such as thinking about words or letters or categories. And that's why we don't see activation here. But this is a very important area. Defoe et al. Has noted that this area has the highest rate of speech arrest for any cortical site, and it has very limited plasticity potential. In addition, Bizzi et al. Noted that gliomas involving the ventral premotor cortex, again, this area, has a 5-time increase in aphasia when compared to gliomas involving traditional Broca's area. So it is very important to localize this area to determine if it's involved by glioma or not, and to spare this area. Here's an example of Wernicke area activation in the posterior temporal lobe. Here it's actually hovering over the superior temporal sulcus. So as I mentioned, fMRI is an indirect measure of neuronal activation and is related to blood flow and blood vessels. So there's a large vessel supplying the area. The activation can hover over a sulcus, and that's what we see here. And so it could be attributed to the posterior superior temporal gyrus, Wernicke's area, or the middle temporal gyrus. So I would recommend stimulation around this fMRI activation. And as I mentioned, the posterior language is much more widely distributed, also including the inferior parietal lobule. And I'll show you an example of an inferior parietal lobule Geschwin activation later. So fMRI is very useful for determining hemispheric dominance, and NECT et al. Performed a study in which they evaluated 300 plus patients, and they found that strongly right-handed individuals, 96, or let's say about 95% of them, were left hemispheric dominant, and about 5% are right hemispheric dominant. So mixed-handed patients or ambidextrous patients still are predominantly left hemispheric dominant at 85%, with 15% being right hemispheric dominant. But interestingly, left-handed patients have much more atypical language distribution. While 70% have left hemispheric dominant, 30% can have either right hemispheric dominant or codominant. So it's very important to do fMRI, particularly in these left-handed and mixed-handed individuals. So here is an example of that. Here we have a left-handed patient, and we have a glioblastoma in the opercular region. And so this is a right between Broca and Wernicke's area. It's a difficult area to perform a resection. But you can see all the functional activation is in the right hemisphere, right Broca and right Wernicke. And so the surgeon can do a very aggressive resection with less concern for damaging eloquent areas. And here's another example in a mixed-handed patient. We see an infiltrative glioma in the posterior temporal lobe, in the temporal lobe area here. And again, right hemispheric activation for Broca and Wernicke. And so the surgeon performed extensive cortical stimulation and found no speech arrest around this tumor and was able to resect the tumor without any speech deficits. So when we think of fMRI, we think that it can provide information regarding Broca and Wernicke, but there's actually other areas which can be identified, and these are called secondary language areas. For example, we can identify the language supplementary motor area, which is anterior to what we commonly think of as the SMA proper for motor function. And so that was very sensitive. Here's activation related to the hand paradigms overlying the hand knob region along the precentral gyrus. And this is the motor SMA. And so anterior to that is the language SMA. And so this is an important area because resection of tumors in this area, in the superior frontal gyrus, can result in a language supplementary motor area syndrome. And so the patients can have issues after surgery with speech initiation, reduced spontaneous speech, and some of them can become mute. This is a difficult area to perform direct cortical stimulation with only 60% of patients with postoperative language issues showed positive stimulation. And Nelson et al. Showed 100% risk of postoperative SMA syndrome when the resection was within 5 millimeters of the fMRI activation. That all being said, it's well known that SMA syndrome is transient. Usually recovery is within 2 to 4 weeks. And it's felt that due to cortical plasticity to the contralateral hemisphere SMA, the patients can recover function. But this is valuable to know for preoperative planning and also informing the patient of potential deficits after surgery. Another area that we can identify is called the dorsolateral prefrontal cortex. Now, this is in an area of activation, but typically is situated over the middle frontal gyrus, the posterior aspect of the middle frontal gyrus, as you can see by the arrow. Now, this area is involved with verbal working. It's a verbal working memory area and information integration area. Antidotally, it is strongly activated in complex languages such as Chinese. So direct cortical stimulation can result in dysarthria and anomia, but Sinai et al. Found that this only occurs in about 10 to 20% of cases, so not that common, but still worth stimulating if you see activation in that area. And in generally working memory deficits are transient and the patient recovers. The third area we can identify is called the visual word form area. So this area is located in the fusiform gyrus, and then this is the junction of the inferior temporal lobe and occipital lobe, and you can see that here by this fMRI activation. So this area is specialized for the processing of letters, words, and object memory. It has a lot of complex functions, but there is a component for language. It has a direct connection to the inferior parietal lobule, so there's a language connection to Geschwin's area. And so damage to the fusiform gyrus and its white matter connections will can result in what's called impaired letter by letter reading. So the patient has a very difficult time reading and putting letters together to form words, and they develop an alexia. So this can be a very significant deficit. So if this area can be avoided, resection of this area can be avoided, obviously that would be lead to a better outcome. But if it's infiltrated by tumor, you're going to have to take it most likely. So these three language areas, in addition to being secondary language areas, are also useful to look at for determining hemispheric dominance, because sometimes if there's a tumor infiltrating Broca, then there's very little fMRI activation in that area. And Wernicke's area can have bilateral activation, so you can't completely rely on that. So looking at these three secondary language areas can help you determine hemispheric dominance. And so that's a very useful to know. So with regard to the right Broca homologue or right Broca's area, this is an interesting area. And we often see low-level fMRI activation here. And Haladny and others have described that this area has some function in, for example, the emotional content of language, being able to sing, being able to joke around. But also this area has significance in reorganization and brain plasticity, especially in patients who have very long-standing tumors, such as the long-standing low-grade gliomas, and is also, there's a greater plasticity in younger patients in children. And so this is an interesting case of a 29-year-old right-handed patient. As you can see, there's this very bulky infiltrative glioma, a low-grade glioma involving the operculum, the insula, as well as a parasagittal anterior frontal lobe. So interestingly, this patient had no speech deficits despite this tumor involving left Broca's area. And so we did preoperative functional MRI, and we see this activation in the right Broca. And so you have to be very careful with interpreting reorganization. And we do see a little bit of activation on the left side. There's something here. So, I would be cautious in calling this reorganization, but because the patient did not have any clinical deficits, that also steered me towards possibility of reorganization. So this is a patient of Dr. Prabhu's. He did a resection of this tumor, as you can see on the post-op, very large frontal resection, which included the left Broca's area. And he did extensive stimulation, no speech deficit. So we did a fMRI 6-month follow-up just to see if this area persisted. And yes, this area in right Broca persisted. So combining the fMRI findings, the lack of clinical deficits, as well as the intraoperative stimulation, we feel confident it's a true case of reorganization. This is an interesting article that came out of Memorial Sloan Kettering, in which they evaluated 11 neuroanatomical areas that were involved by infiltrative glioma. And they retrospectively looked at patients who on the fMRI had codominant activation, so activation in both hemispheres or towards the right, or in patients who only had left-sided functional activation. So they found, which was interesting, that tumors that infiltrated the basal ganglia resulted in a greater number of patients with codominant or right-sided language function. So it's not clear why infiltration of the basal ganglia would trigger a reorganization response, but it's a very interesting study. And also interestingly, they found infiltration of Broca and Wernicke's area by infiltrative glioma did not correlate with any increase in reorganization. And so I think that was an interesting study. Just important to note that although we see sometimes activation in the contralateral hemisphere, which we may think is reorganization, sometimes this may be an incomplete or failed reorganization. So doing stimulation in this area will not result in any speech arrest. So briefly, with the time I have left, I wanted to touch upon resting state fMRI. And this is a new technology that has come out in recent years. And the patient, it's very valuable in patients that cannot do task fMRI. As we know, there's patients that are too impaired to do any language testing in the MRI scanner. And so we can obtain a 6-minute scan, and all the patient has to do is lay still, not really think of anything, just kind of keep a blank mind, and then stare at a crosshair with their eyes open for 6 minutes. And it's been found that there's low-level fMRI activations even at rest, and we can extract all these motor and language networks, as well as many other networks, such as the default mode network, from this data. So this is a patient, just to show an example. We have this glioblastoma involving the canonical Wernicke's area posterior superior temporal gyrus. And so, there's some edema here as well. And so since we did not have task fMRI, we processed the resting state fMRI data, and we see we placed a seed in the area away from tumor in the normal left Broca. And we see, interestingly, what we call, in resting state fMRI, you call it functional connectivity rather than activation in the inferior parietal lobule and Geschwin's area. And so this is directly above where the traditional Wernicke's area is. And so the surgeon performed a resection of the tumor here, and there was no new postoperative speech deficit. So resting state fMRI is a very exciting technology, and actually MD Anderson and Washington University in St. Louis are the only two institutions that I'm aware of that are using it for clinical purposes. But this is an evolving technology which will be coming out more and more. I did not have time to cover diffusion tensor imaging, but as I mentioned, it's very important to identify the eloquent areas as all of the white matter tracks connecting these areas and around the tumor. And so this is an example of an insular opercular glioma. It's a low-grade glioma. And so for preoperative planning, we generated the tracks around the glioma, including the corticospinal tract in blue, the frontal A-slant tract in green, the arcuate fasciculus in orange, and this is the inferior frontal occipital fasciculus, which runs just deep to the insula. And so, unfortunately, I didn't have time to cover resting state and DTI in detail. Those are separate talks, but I just wanted to briefly introduce them. I also want to note, if anyone in the audience is interested in learning more about functional MRI, I run a webinar every other month in which we show fMRI cases for the American Society of Functional Neuroradiology. So if you're interested, you can email me at vakumar@mdanderson.org. I'd be happy to add you to the distribution list. With that, thanks so much for your attention.